So it's like, hey,
Now, when I was going out there and I met with you, I don't know how many years ago that was, but at the time, your lists could get up to 30 and 40 encounters per given day. Is that still about what you can
yeah, yeah. I have
wow.
39 patients booked tomorrow between 8 and 3.
You are my hero, John. I because to me, I would be nearly incontinent with concern as to how I would do that many. But also, I'm assuming you don't even have you gone over your list? Do you know that you're going to be seeing uh, uh,
No,
four CMC joint,
no,
one?
no. It just they book it. I turn up. I click on. I see the patient notes and request details before a couple of moments before I call them in the room.
You are you are my hero. So this is 2 days a week,
Yeah, yeah.
and your private you, that's a contract engagement that you have, um, and that you could just simply tell whoever, hey, I'm not going to be there for 6 weeks.
Yeah, if I give them notice, it's a couple of companies and that I do that work for, and I just gave them a couple of months notice, and I said, I'm going to be away for these 4 weeks, for these 5 weeks, and
And was it good? Was it good for you, John?
I think so. It was a lot of it was childcare, but a lot of it was nice childcare, so you get time with the kids and stuff like that,
Were
and
you camping? Were you at home? What were
we
you?
did bits of all those things. We did a bit of camping. We did we had one or two camping trips, I think, and then I took the boys to Stonehenge, and we went swimming. We went paddleboarding and stuff like that. Just stuff that's nice to do, and lots of just running around. And it's where we live is quite a nice place, quite a nice part of the world. So and the kids have lots of friends to go and visit, and so we did that sort of thing. I went up to see my mum, who's that was her birthday, her ninth birthday.
Yes. Is your mom living in her own home and all that kind of stuff?
Yeah, yeah. She still lives. She lives up in Liverpool, so and she's 96, so she's getting on a bit. So we went up there, and the kids play in the woods around where she is, which is good too. So
I'd
wait,
forgotten if you have siblings.
yes, I have three siblings, so they were around, and we don't see. I see some of them sometimes, but it's where we try to always be, one of us is visiting, or the other one is staying there. So there's usually someone around because help look after my mum. So we can't tell her that.
That's very nice.
So what was
Now
your
that
summer like?
my summer um was really pretty much
Can you close
just
the door? Can you close the other door? No, that door. Go the other door, please. Sorry, the acoustics here is terrible, and but
that's all right.
we're
No
doing stuff.
worries.
And we can't shut the doors, and the sound is bouncing everywhere.
Oh my, sorry.
No, it's all right.
Um,
We've set the room up to have the piano in here, and my voice echoes every time I speak, so it sounds like I'm in a big room.
you have a filter, an old synthesizer filter on that gives you the resonance into the wires as you talk.
Yeah,
Interesting. No, I because I really don't have much clinical time scheduled. I've gone into that mode that basically says I do scans whenever they become available, and I've started most recently to work a in a setting of oversight management in a nursing home. So the mechanism is that our mid-level physical therapists or physical therapy assistants do the majority of the care, but to admit them, to change their plan, discharge them, and if anything comes up where it requires what they think to be at an elevator thought, that they call they call Obi-Wan and ask. And so it's one of those things that I will work maybe 5 to 10 hours a week in that capacity,
Yeah.
and fly maybe once every 2 weeks out to do enough scans to barely cover my fuel, but at least it's a tax write-off,
Yeah.
for to get there. So that's kind of what I've been doing, and the summer has been just really beautiful here, as the rest of at least this nation has either burned up or flooded out.
Yeah.
We've just, knock on wood, been so fortunate here, and so
But it's
yeah,
it's is that, are you enjoying this semi-retirement?
I'm enjoying it. Huh? I'm 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 enjoying it because I'll tell you how I know. When I think about going back to work, I don't want to.
Yes. That's I couldn't say I enjoyed the month off, but when I thought about going back, I didn't want
Yes.
to.
that's
Yeah.
that's the bottom line. It has a lot to do with I don't want that. And so I will have to tell you, there's a large, even heavier load of frustration, as during this summer I devoted a lot of time, okay, some time, to to connecting with my peers, just asking if they would be willing to let me come and do a dog and pony show with
Yeah.
ultrasound, to at least give them some exposure to what ultrasound would allow us to do in the
Yeah.
clinical setting. And I probably canvassed 30 standalone sports orthopedic clinics
Yeah.
in the all the way to the Canadian border, and
Yeah.
down to where I was. And one clinic got back and said, "We'll make available a noon visit with you. We'd like to have hoagie sandwiches and salad." And it's like, what? I you know I became a salesperson,
Yeah.
and it's just so disappointing to me when my heart says, "Are you high?" Because
Yeah.
I'm going to show you things that you can't even believe that you can even see.
Yeah.
And so I'm still crawling out from under the, I cannot believe my own colleagues are just simply saying, talk to the hand.
Yeah.
I don't see any value in that as it relates to what I'm doing.
Yeah.
And
Yeah. Well, that
and
that that's been that was my experience in England 10 years ago. But the nature of the services where we are is very different. So a lot of the interest in ultrasound is driven by injections.
yes,
You know.
an interesting thing though that I think is still a unique juxtaposition to me. I I am I'm baffled by how my own colleagues won't even give me the same platform that they would give essential oils
Yes.
or other stuff to come
Yeah.
in and just look, you need Con Ed for your clinic. If nothing else, just bring me in. They won't even do that. But the
Yeah.
other side of that coin is, today I have 4 people who were referred to me directly, and they're each happily paying $200 cash for my
Yeah.
diagnostic work. And and I'm I'm becoming more and more convinced that if I went direct to the consumer, which we certainly can do here, and I don't know if you can do there, but if I can go direct to the consumer, they get a diagnostic scan, they get a conclusion to what I'm seeing, and they get recommendations for what they can do at home. And there's no middleman. It's direct from the hurting patient
Yeah.
to the scan, and they just simply,
Yeah.
happily put down cash. And I'm sorry, but a day when you have 4 people like that, when you can go home, I have not focused on going direct to consumer like that. Like go through TikTok or Instagram or Facebook. I haven't done any of that because I originally wanted to go to the orthopedist and say, bring me on as an ancillary scanner before
Yeah.
you even see them.
Yeah.
No response. And then to my own peers to say,
Yeah.
hey, you guys, don't you think it would be nice to know? But now I'm just realizing that the human who recognizes they do not need to even see their family doctor to get at least someone's opinion, who has
Yeah.
tenure in the clinical arena. And
Yeah.
anyway, that's my sad story of my summer, is further
Yeah.
realizing that though I'm yelling, we have a fire, nobody
Yeah.
seems to care.
No. No.
But
Well,
tell me,
I'm
I'm curious to know, tomorrow when you have 39 people, is that all interventional, or is that
no,
interventional diagnostic? What is
no,
that tomorrow?
it will all be diagnostic.
And from there, you will either, so you won't even set up for your own injections
No,
in
I'll
the,
do no injections at all tomorrow. I will just it's a National Health Service list. They will have booked in patients that have been requested by someone else asking a question. So they'll all be question related. It will be, what's the matter with this shoulder? What's this lump? Why is this patient got pain in this area, etc., etc. All through, all one line. Most of them will be one line questions, and I will scan them and give them one line or 2-3 line answers.
what about that? And so you're also not doing a protocol scan. You're doing a scan that's focused on giving them the answer to their problem.
In the UK, fortunately, we are not as tightly bound to the protocols as they are in other countries. But that's not to say that all people in the UK, a lot of sonographers in the UK work very closely on protocols. I am senior enough that I can judge what needs to be scanned based on what the patient is telling me. So it is a quest. It's a request for a scan is a request for an opinion. So if I'm asked to do a knee because they have pain in the knee, I will look at why they have the pain, and I will check, see what else is going on in the knee. So you'll get a knee scan like the one you see in the book. It may not be in any particular order, because I will just be asking myself a question. I will be looking at the knee to see if there's swelling, checking the extensor mechanism, looking at the specific reason they've asked for, and then I will just have a quick check around the joint lines, just have a quick look at the ligaments, the pairs, and in the popliteal fossa to make sure there's nothing exciting going on there. And I would look at those things, and I'll take a few pictures that will tell the story, and then I'll write a report.
Supposing they had a inversion ankle sprain, and the person is saying, is there a compromised ligament? Are you going to drop a tarsal tunnel? Are you going to look at the deltoid? Are you going to check the knot of Henry? Are you going to do stuff like that?
Yeah. But I mean, that takes a couple of seconds, though.
Yeah. You're just going to do a dynamic passover and look for hypoechoic
Yeah. Well,
areas.
I'm going to look at the bit. If they've twisted their ankle and they're getting lateral ankle pain, then I will check the perineal. I will go. I will probably start because it's an ankle joint. I will have a look at the front of the ankle, just because that's a window to gives you an idea
Yep.
of you wouldn't want to miss any pathology there. And then I would probably check syndesmosis, just sweep down through over the ATFL, and the other lateral ligament structures, whiz around the peronei. I would probably check the sinus tarsi and the proximal tarsal joints, and have a quick look at the Lisfranc region, and then roll round. I probably wouldn't look at the Achilles unless I would look at the Achilles, but I wouldn't study it. And then I'd have a quick check of the medial side. So you come down the tarsal tunnel, look at the deltoid, for want of a better word, but the Tom, Dick, and Harry, and the nerves sweeping round. And I might get as far as the knot of Henry. If it was a lateral ankle pain, I might look in the base of the foot and just quickly check the distal part of the peroneus longus and just check its insertion. But it depends how enthusiastic I was feeling and how much of the answer I'd got already. But that, I think, is a fairly reasonable thing to do, and it doesn't take it only takes a few seconds to do most of that. But you're having a quick check to make sure you've got the whole story. You're listening to what the person's saying, and you're figuring out what the problem is.
So of the 15 minutes that you have, taking a history, let's say anterior hip, felt a pop. Now you have some swelling in mid thigh, and some pain with the extensor mechanism, and you're questioning whether or not it's the indirect or direct head of rectus femoris. Are you going to be taking a look at piriformis? Are you going to be looking at sciatic? Are you going to be looking at the gluteal muscles?
If it's anterior hip, then there's no indication to look at the back.
Yeah, I'm with you.
Thigh.
Hey, hi, good night. Do you look older?
Hello, this is my friend Greg.
Hello.
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 Where's Mummy?
She's upstairs.
Okay.
I'll forget.
This is number 2 or number 3?
Number 2.
Number 2.
Oh,
with an attitude. I like that. I like that.
You need to close that door. The acoustics is really bad. This one stays there, but the other one shut. Christine's gone to IKEA and bought a new bed, so the bits of the bed are blocking the doorways and everything. So they're yet to be constructed, so we can't shut the door, which makes everything very echoey. This is why I'm frowning at them.
I'm just glad to connect again, and I'm looking forward to, out of 30 some scans, there's going to have to be 1 or 2 things that you can find that can.
There is always something interesting. There's never a day goes by when there isn't something interesting come up.
Isn't that the truth? If you have anything to share, I'm all ears and eyes.
I have.
At the same time, don't feel like you have to, John. I don't mind connecting.
I haven't, as say, I've only scanned 2 days. So there is not a huge amount of stuff around, but I did see.
How much hands and elbows do you have in comparison to hips, knees, and feet? Or is it just pretty much general?
It depends on the day. Elbows are not a big thing, but I see a few of them, but I don't scan a lot of them every week. What on earth did I see? Let's have a look. Let's share for a moment. Oh, you've disabled sharing. Can you enable sharing?
Hang on. Let me see if I can do. Oh, share. Oh, that's asking me to share. Meeting settings. In the world, participants, John. Request camera rename. I'm gonna make you the host. If I make you the host,
I'm host.
that's got to allow you to.
I'm the hostess with the mostest.
That's right. Are you able to do it now?
I think so.
Oh, good. Yes.
Let's have a look. Right. So, does that work? Probably does.
Yep, I've got it. I've got it perfectly.
Yeah. So that looks a bit like a Morton's neuroma. This patient had no pain at all there. A little bit of tenderness, but they didn't have any symptoms. And you often see a little bit of fluid and a little bit of stuff in there. And it's very easy to call that a Morton's. In fact, if they were painful, I might be tempted to. But this is something that you don't see every day. How well can you see the pictures in there?
I can see it quite well.
Okay.
Is this anterior knee?
Yep. So what do you think of that patellar tendon?
Wow.
You see how the two parts of the tendon are crossing over?
Yeah. What's going on?
So that was a tendon transfer, a partial tendon transfer.
They're trying to redirect the vector pull in the trochlea. They're trying to offload the.
Yep.
What about? Let me see that again. Oh, I've seen them do that. I've been in surgery when they've done that. That was like back a few years ago, though.
That was a long time ago. This is a very long standing.
Yes.
But you don't see it every day.
No, that's a novel idea. I've never seen it on cross sectional. Wow, how cool is that, John?
Yeah.
Let me show me the tibial tuberosity again, so we should be able to see a harvest part of the bone area. That's amazing.
I didn't spend it wasn't symptomatic, so I didn't spend a lot of time on it. I just thought, it's one of those things in passing that you kind of look at.
Did they say, hey, I've had my patellar tendon transferred, and you said, oh, I'm going to take a look at this?
Well, it was more a matter of me having a look and going, say, yeah, this is not entirely normal.
Wow, now this is a tendinopathy for sure.
Yeah. And what's a little bit more interesting, it's just a tendinopathy. But if we go and have a little look, can you see? We come back here. This lining, and I'm not an expert on patellar tendon. This line thickening here, it almost looks like a paratenon. I thought it was a bursitis, yes. But bursitis doesn't normally look that. It's almost like a thickened paratenon.
Just a second. You when you say that the bursitis doesn't normally look that way, are you saying that the color is not as anechoic as you had liked, and that it's showing that
the structure of it. This looks fibrous, and it's thin and fibrous, and the bursa is still a bursa. When they're abnormal, they don't normally look like that, and yet we don't normally see a thickened paratenon on the
patellar tendon.
But I think that's what it is. So, I will run that
because the patellar tendon doesn't have a sheath. It's very much like the Achilles tendon. Then I've never known it to have a paratenon. Interesting.
Well, this is something that I will have a look into and see whether that is the case. But yes, not something I'm very familiar with. This is some gluteus medius tendinopathy, but it's on the iliac crest.
Oh, wow. And you know that that's a gluteus medius tendinopathy because of you scanned it. How would I differentiate that from like ITB or even
Can
a
you
TFL?
differentiate that? It was very anterior, but the ITB comes. Those fibers are shared.
Yeah.
So I suspect it's something in the middle. You know, it's
Yeah.
but it's that area.
That was that clearly is hypoechoic for sure.
It's low echo. It's thickened, and it is that origin of the iliotibial
Yeah.
band, and
That
the
that's where the
and
pain
the
was.
muscle underlying it. But yeah, it's what do you do with those?
Yeah.
So
I
some
I
physio,
miss
possibly some shockwave.
I miss your sono hack. You had one on medialis and I mean the medius and the minimus, and I
Yeah.
have had today. I had two hip scans, and my level of ignorance when I haven't done them for a couple of weeks. I don't know.
Yes.
I cannot believe how my brain reverts back to total stupidness when I'm trying to get the elongation, oh, that's an anterior and that's a little more lateral. And sometimes I
Indeed,
feel like such a loser.
I sweat on those as well. So, and I've been doing it a long time. So I still find it a real, I don't love this the sensitivity and specificity of ultrasound for that. Yes, you can see it. Yes, you can diagnose stuff, but you don't see it anything like the clarity or with anything like the confidence you do with the rotator cuff. We're just not there with the imaging. It needs.
I guess
get better.
Where I default is going short axis on the femur until I see that the roof peak, and then I go anterior and I start turning short axis toward the opposite shoulder or whatever, and I try to look for the cross sectional wad of the minimus, and then I go back and I don't not 75% of the time I'm feeling like a poser on that still.
Yeah. Well, it's the thing is, if the patient has a lot of fat there, which a lot of patients do, and females particularly, but some men sometimes too, they naturally deposit. Even relatively slim people have quite a lot of subcutaneous fat there, and if they're a bit old and the fat has become fibrosed, then the picture quality falls down very quickly in that area. So it is just hard to see, and there's not really a way around that. I'm just trying to think. I have recently tidied up all my stuff, so everything's now in my archive. So I haven't got a lot else to show you today, but
okay, that's fine. I'm happy to connect, and it's always fun to dialogue, and I still have an interest in while I still have a viable business that I can write stuff off to. I'd like to come and be an observer under your tutelage, so that whole thing.
You should come and visit. You should come next time you come over. Make sure that it's on a. No, she was upset. Shut the door for me, Shut the other door. Yeah. No, so you want to come over and visit, and just make sure you've got time to. You let me know, and you've got time to sit in on a list and just come in. I'm sure you can get. We can figure out. Sometimes you have to figure out the permissions, but they're always obtainable. And just come along and sit in on a list.
I would like that, because to me it would be very enjoyable to hear the process, the questions that are the most productive in giving you what you need to have from people of varying personalities that either overshare or undershare, and watching John edit.
I'm quite good at getting the right amount of the right amount of information. I got some very good education in that. And
wait a minute. You're implying that you had actual tutelage in how to do it correctly, and this was not John just saying, let me show you how the master does it. You actually have individuals?
No, I can't say individuals. There was a book that I read that was very instructive, and then it's a combination of lots of things over the years, and seeing a lot of patients and trying to do it particular ways, and I found that there's a rhythm to how you try to, because the trick is to put the person at their ease. The best way to avoid oversharing and the other things is to put the patient at their ease, but have a definite structure to how they walk in the room and how the conversation goes. So if a patient tries to, if while I'm doing all the admin stuff, a patient tries to engage me in conversation, then I'll politely tell them I just need to concentrate now, and then I make sure that they know that I will talk to them if I need to be quiet. And then when I'm scanning, it's the same. If they're a chatterer, I explain to them that I make most of my mistakes when people distract me, and so I just need to concentrate. And then people are always very happy to be quiet.
I love that line. Look, I make most of my mistakes when you're talking.
Yeah.
Well, because it uses bandwidth.
Well, I have a very old 286 chip up there, and my memory is a little tape recorder that you have to press 3 buttons on to store it.
That's right. I remember that.
And I'm afraid it's a single core processor. They know that. Single core processor. You can either have chat or diagnose or accurate diagnosis, and there's no option. I can't chat well and I'll do a rubbish job. But if you just ask people to be quiet, that worries them and frustrates them. So I just say it nice and clearly, not always the same way, but actually I give them reason, saying, I have to work when I'm quiet. That doesn't work. Over the years, when I've told people that I need them to be quiet, that doesn't work. You tell them I make mistakes when people talk to me. Their self-interest is then appealed to consciously.
Yes.
And they don't talk. The vast majority of them. And then but they know that I will talk to them, but just while I need to concentrate. And the truth is, it's a really sad thing. Truth is, there's a little voice in my head that is talking to me all the time when I'm scanning. And if no one's distracting me, it's saying things like, well, have you thought of that? And have you thought of this? What's going on? And what do you think that might be doing? And why is that? And it's just in the back of my head, just going on all the time. But when someone talks to me, tries to create a conversation or argue about something or discuss something, then I'm thinking about them. And that little brain stops talking to the picture. It's talking about the picture.
John, that's brilliant. That alone is such a nugget of value to people who are starting up, who think that they can multitask. Because I really think that what you're saying, your excerpts from books or videos are saying, did you do this? Are you looking at that? And any type of even honking can take that person out of the picture. If you hear a jet flying overhead, I'm way off that. Let me ask you this: how much manual orthopedic testing are you doing between, let's say, their history and your scanning?
Nearly none.
So you won't do any kind of a pivot shift. You won't do much like.
I might, but it's in general. It's like the old. I used to teach. I used to work in a specialist shoulder unit, and so I got very slick assessing shoulders, and I used to teach my juniors that there was nothing you couldn't get in a one out of more. You only needed 1 minute to do a complete physical shoulder assessment. And so I used to do that before each scan. And over the years, it got down to, I would look at, I'd hold the elbow by the side and I would look at external rotation. And that and the history kind of got me 99% of where I wanted to be, in combination with an ultrasound scan. Because you're going to see what they do when you move the arm and things like that. And I'm going to put the arm up to have a look in the armpit and things like that, because I like to scan the armpit as well. And so I no longer feel the need to do that, because it is the story in combination with the restriction in the capsule and then the ultrasound that just kind of puts it all together for me. And I'm not left wanting anything else. And so I don't. And even with ankles and things like that, I want to know whether they're a little bit unstable, but I'm going to test the instability while I'm scanning it. And if I'm looking at them clinically, this is in the radiology setting, there's very little. In the orthopedic setting, that when I have 10 patients a day, that's a little bit more, but not a great deal more. I'm more interested in what's bothering them about it, and then narrowing down my differentials. And with ankles, I will get them to go up and down, particularly if they're a bit non-specific about where they're hurting or how much it's hurting. Then I want to maybe see that. Knees, not really using ultrasound to do primary diagnosis on knees. Really, I'm usually answering a question there. So if a knee comes to me in an orthopedic sense, then it's usually for some sort of intervention, in which case the vast majority of them have OA, and I'm more interested in how much it's bothering them than the actual physical limitations. If they come in and they can't fully extend the leg, that I'll know that when they lie down, and I'll know what their flexion is when I move them up to look at the trochlear groove. So those are my go-to things. And after that, the pathology you're looking for in a knee it's OA, meniscal problems. You're going to be looking around the joint line, all your clicks and things there. Occasionally, when patients come in and I have a suspicion someone's missed an ACL, and so they've ended up on my list for a random reason, and I think they've missed an ACL, then I will get on and I'll do a Latchman's. I don't rate the pivot shift at all as a test. When I was very young, I worked in Norway and in Denmark briefly, and did a lot of ACLs and a lot of acute ACLs and the rest of it. And I found that a good Latchman's done well was on a par with any other test. And basically you're just saying, do you feel there's laxity in the knee? And I think that's what all your testing is. I don't think any of the tests are reliable in terms of pivoting and the rest of it. I think they would give you an opinion, but it would still be a toss of a coin whether it's right or not. So I just want to know, do they have peripheral damage, which I'm going to see on the ultrasound, or major meniscal pathology? You're going to get an impression of at the very least on ultrasound generally with the effusion, and then it's and do they have laxity? Do they have a history of giving way? And then you're saying, well, once in a blue moon you see something in the ACL when you look at the ACLs that might make you even more suspicious. And occasionally I'll have a quick look at the ACL just because out of interest, but I don't think it's reliable. But if I suddenly see a lot going on there, then I can write that in my report to give more oomph to get them an MR. But that's the test for that.
John, I would like to have two things. If that voice in your head can be quiet enough to hear Greg ask you while you're doing some scans, and my voice would say to you, can you capture some of your axillary imaging and let us dialogue what you're looking for when you do that? I have to say, I do not do any of that unless I'm specifically trying to identify thickening of the capsule. But even then, I guess I would like to, if you're willing, and if you have somebody that you're going to do some axillary type scan on, I'd like to hear. I
do that on every shoulder. I scan every shoulder armpit, and I don't think it's reliable at all. But yes, I'll show you some auxiliary scans of the shoulder. I don't know whether I do it well or not, because no one particularly does it around here, but I just do it because I've done so many shoulders. I've got so much, even in my 10-minute appointments, I have plenty of time to have a look at things that I'm interested in.
You do it well, because that's my reality. And I know that a person that's done it more than twice, or more than 20 times, or more than 200 times, have varying levels of goodness. I just want to know what's going through your head as you're scanning it. And if you could do that. The second thing is the ACL. If you have some knees, and if you were to just capture some, this is where I would look for the fluid, and this is how I would do that. Both of those things I think would be valuable for me to see in real life type stuff.
Well, I'll take some clips and I'll show you. Yeah, but I say the ACL, I know people have published it, and so there are people out there who are probably good at it. I am not good at it. I just look because it's there and it's interesting, and I look at stuff that's there and interesting.
But the more you look at stuff that's there and interesting, the sooner you're going to be able to identify that part that is not like most of the others.
Yeah,
and
so that's why I do
nothing
it.
Else. Yeah,
but I don't. I would be reasonably confident to say that until something changes in the technology, we are not going to have a reliable ultrasound test for ACL. I know people have published it on very, very acutes. I'm not. I'd be interested to see whether anyone reproduces it, because I look at them with, and obviously I don't see the acutes, and I don't see people with their confirmation, because they're not coming to me for that. But I look at it, and it's not easy to see. And in cases where I know it's gone, I can't be confident to say I see it, and vice versa. When I know it's intact, I can't always put my finger on it. But I like to look at these things, and I'll make, in a year's time or 2 years' time, I'll be more confident than I am now, if I'm still working.
or if maybe you're coming out and visiting me, as we both just dabble a little bit with our passion. I'm gonna need to bow out a little bit early. I've got to make it to that nursing home in time, John.
That's all right.
Let me say that I'm going to reach out in 2 weeks for another one. If you can't do that, that's fine. But there's some other things that I had started to write down at home that I did want to talk to you about, that I'll bring up when we talk again. But other than that, it's always good to see you. Tell your family hello.
I will.
And
we will. And I'll see if I can take a couple of some clips of some armpits and some knees, anterior.
That would be great. And anything else you find that's cool, I would love to see that.
I will see you later.
Thank you, John.
Cheers.
Talk to you later.
Bye-bye.
Bye-bye.